time I was asked to come and speak about two new molecules, which were the amylin analog pramlintide and the first GLP-1 receptor agonist, which was exenatide twice daily. I was working for Amylin Pharmaceuticals at that time, and this feels very similar to that. Those were two first-in-class drugs. People did not really understand the mechanism of action of amylin or of GLP-1 receptor agonists, and we've come a long way. And what we're going to be speaking about today is what I think is extremely exciting, and that's why I'm at the company, which is a new mechanism of action which has the potential really to revolutionize diabetes care. And we clearly have some clinical work, as you'll see, still to do, but it's extremely cutting edge. And I'm joined by, and she needs no introduction, Professor Juliana Chan. I think most of you know her, an endocrinologist, clinical pharmacologist, and diabetes researcher. She's professor of medicine and therapeutics at the Chinese University of Hong Kong. She's also the founding director of the Hong Kong Institute of Diabetes and Obesity and the chief executive officer of the Asia Diabetes Foundation. She has, over a long span of her career, worked in epidemiology, done a lot of work in genetics, clinical trials, data-driven clinical management of diabetes. I don't know where she gets all her energy. I'm told oftentimes I have a lot of energy, but this woman really has a lot of energy. I've had the great pleasure of working with her over the years in a number of ad boards and CME programs and whatnot. Prolific publisher, over 900 articles and 20 book chapters, and has over the years received a number of awards, including the very prestigious ADA Harold Rifkin Award. And these are Professor Chan's disclosures. So Juliana, great pleasure, and thank you very much for joining in this symposium. And Juliana is also on Biomea's scientific advisory board, so we're very lucky to have her on that global advisory board. So here's a quick agenda. After I quit introducing and going through agendas here, we're going to give you a quick introduction to Biomea Fusion, so our company, which is headquartered in Redwood City, California, and also the role of Menin, of the protein Menin in glucose homeostasis, and discuss the covalent oral menin inhibitor, icovamenib. Previously, we referred to it as BMF-219, and its role in diabetes and our studies actually that we're conducting in type 2, and I'll touch a little bit on type 1 diabetes as well. Professor Chan will then talk specifically about subgroups and subtypes of type 2 diabetes, and a little bit about type 1 diabetes as well. And then I'll wrap things up with a case study of a patient with insulin deficient type 2 diabetes, and actually show some very interesting data about the effect of menin inhibition on GLP-1 receptors as well. And then we'll have hopefully some time for Q&A. So a brief introduction about Biomea Fusion. So we're a clinical stage biopharmaceutical company. Again, we're headquartered in California. And this shows our executive team, many of whom are here. Our CEO, Tom Butler's in the audience, our Chief Operations Officer and co-founder, Tom and Ramses, who are here, co-founded the company. And Tom is an organic chemist, a medicinal chemist, and he's been involved in drug discovery for many years and discovered some very important medications over the years. So basically we have a team, many of whom have worked together for a long, long time and a lot of experience in the pharmaceutical industry. And we have three development programs in oncology, diabetes, and now in obesity as well. And they really have the same development principles, and that is that we go after validated targets to improve the likelihood of success, and generally doing so with covalent small molecules. And this provides very deep inactivation of the target and actually allows for a much wider therapeutic window. So with lower PK or pharmacokinetics, getting a larger pharmacodynamic effect. And then the third thing, which I think is extremely important, we'll talk about where we're headed towards that with diabetes, is combinational therapy. So combining therapies, or combining, I should say, drugs with mechanisms of action that are complementary, both in oncology and also, as you'll see, in diabetes and obesity. So with respect to our pipeline, icovamenib is a covalent menin inhibitor, and this is in development currently in phase 2 for type 2 diabetes, which is going to be the focus of this talk, but also in patients with type 1 diabetes. And then recently we announced our discovery of a new oral small molecule GLP-1 receptor agonist. And these molecules, or these drugs, are all developed in-house, and that's an early stage of clinical development, and we think it'll be a very nice combination with a menin inhibitor. So with respect to the role of menin in glucose homeostasis, and specifically icovamenib, the covalent menin inhibitor, I'll start by stating something that I think you know very well, which is that the root cause of diabetes, on the left type 2 diabetes and certainly type 1 diabetes, is a progressive decline in beta cell function. So we all have patients with overweight and obesity who are extremely insulin resistant who do not have type 2 diabetes because their beta cell is very robust and it's able to compensate for the insulin resistance and maintain euglycemia. But in people who develop diabetes, we know, again, looking at the left-hand side there, that at the time of diagnosis have already lost 50, maybe 60% of their beta cell mass and function, and this continues to decline. So the natural history of type 2 diabetes is one of a progressive decline in beta cell function. In fact, it's been estimated, and this is work done by the UKPDS, in the UKPDS database, and other studies, that it's about a 5% or so loss in beta cell function per year. Another very important principle, and certainly when I did my fellowship many years ago, we just sort of lumped type 2 diabetes was sort of like one disease, but we've really realized that this is extremely heterogeneous. And there have been many groups over the years that have subtyped type 2 diabetes, and probably the most prevalent one is from Leaf Group and Emma Alquist in Sweden, looking specifically at subtypes of type 2 diabetes. Pre-diabetes, clearly a risk factor for type 2 diabetes. I think we can touch on that a bit. I think that also is a very heterogeneous condition, and potentially a menin inhibitor, which proliferates beta cells, would have a role in some patients with pre-diabetes. Clearly type 1 diabetes, there's a very significant decline in beta cell function. But amongst patients with type 2 diabetes, and the clustering that was done by the Alquist group and Leaf group looked at hemoglobin A1C, HOMA-beta as a measure of beta cell function, HOMA-IR, a measure of insulin sensitivity, BMI and age of diagnosis, and group patients into different subtypes. And the SIDD, or the SID, severe insulin deficient diabetes, and also MARD, mild age-related diabetes, are patients who are insulin deficient, significantly insulin deficient, where insulin deficiency is the primary driver of their hyperglycemia. And in fact, the work that was done in Sweden has been replicated in many databases around the world, and it's estimated that about 50 to 70% of patients with type 2 diabetes, actually insulin deficiency is the primary defect resulting in hyperglycemia, characterized by a low BMI, less insulin resistance, and low insulin production and beta cell deficiency. And a little closer to home here in South Asia, this has been done, and this was done by Dr. Mohan in over 20,000 or close to 20,000 patients at 50 centers, looking at the Indian population, and there slightly over 60% fell into the SID or the MARD category, so the insulin deficient categories. And they also sort of had a new category, if you will, which was a mixed category of both insulin deficiency and insulin resistance. So this, again, across populations has been shown now. Turning now to menin. So menin is a scaffold protein. It's primarily found in the nucleus of cells. In and of itself, it does not have much action, but when it binds to or complexes with protein binding partners, it plays a significant role at the level of the beta cell. And you can see on the left here, I'm sorry, let's go forward. On the left here, binding, for example, with MLL1, here we go. There's menin, it complexes with other proteins, and it activates, there's activation of beta cell growth repressive genes. And when it binds with other proteins, there's actually repression of beta cell growth promoting genes. So the bottom line is the menin at the level of the beta cell puts the brakes, if you will, or suppresses beta cell proliferation. And if you look at the second bullet here, so inhibition of menin actually enhances beta cell proliferation and function. And what's been shown, this is physiologically, this has been shown in a number of animal studies as far back as 2007. So this is work from Stanford University, basically shown in a murine model, so in pregnant mice, that the increase in prolactin that's seen during pregnancy actually reduces menin levels and menin activity. And what it does is it enhances proliferation of beta cells to compensate for the insulin resistance and maintain euglycemia. So this is a physiologic mechanism by which suppression of menin increases beta cell mass and insulin secretion to maintain euglycemia and prevent gestational diabetes. So what we're doing with our menin inhibitor, which is icovamenib, is inhibiting menin activity. And you see here, icovamenib binding with menin, not allowing it now to bind or complex with these protein binding partners. And in this case now, you get inactivation of the beta cell growth repressive genes and activation of the beta cell growth promoting genes, and you get beta cell proliferation. Very importantly, in the experiments that we've done in preclinical studies, we see that this is glucose dependent. So it only occurs at hyperglycemia, and you don't get over-proliferation of the beta cells. And this is just one of many experiments that have been done in islet microtissue. So these are human donor islets. And what this is showing here is beta cell proliferation on the y-axis with different doses of icovamenib over different periods of time. So here shown 1 week of treatment, 2 weeks of treatment, and 3 weeks of treatment at 3 separate doses. And this is at hyperglycemia, so 8 millimolar or about 145 milligrams per deciliter. And what this shows, and the control, actually the active control is harmine here, is that you get a dose-dependent and a time-dependent increase in beta cell proliferation in these islets. We do not get proliferation of non-beta cells, so alpha cells and delta cells. And not shown here, but in experiments where you withdraw the icovamenib, the proliferation stops. Also at euglycemia, so when these experiments are done at 5 millimolar or 90 milligrams per deciliter, you don't get the proliferation, which I think is extremely important. Let me go through a couple of studies that have been conducted to make a few clinical points here. So this was our multiple ascending dose study in patients with type 2 diabetes, in which icovamenib was dosed for 4 weeks. It was dosed daily for 4 weeks. Background medications were continued, and then the icovamenib was stopped. And we followed these patients for an additional 22 weeks. So what we'll look at is the hemoglobin A1C change at week 26, 22 weeks after the icovamenib is stopped. And these were all adults with type 2 diabetes. The duration of diabetes up to 15 years. They were poorly controlled on background therapy up to 3 agents. Many of these patients were on metformin monotherapy, but some of the patients were actually on triple agent therapy. For example, metformin, an SGLT2 inhibitor, and a GLP-1 receptor agonist. And the primary endpoint of this multiple ascending dose study was safety and tolerability, but we also looked at hemoglobin A1C and continuous glucose monitoring and fasting glucose. And I'm going to show data from the 100 and 200 milligram doses, and these are the doses that we've taken to the next phase, and I'll talk about that in just a bit. And what we saw in these patients, and again, we need to keep in mind they continued their background therapy that they were not gaining control with, and they were treated for 4 weeks with either 100 or 200 milligrams. But at 26 weeks, over 5 months after stopping therapy, 20% of the patients treated with 100 milligrams once daily had a hemoglobin A1C reduction of greater than or equal to 1%, and almost 40%, 36% of the patients treated with the 200 milligram dose had a hemoglobin A1C reduction of greater than or equal to 1%. If we look at all of the patients, the 31 patients treated with 100 and 200 milligrams, you see that 40% had a greater than 0.5% reduction in A1C, and over a quarter of them, 26%, had greater than 1% reduction in A1C. Now, we felt, based on the preclinical work and some of the islet work and the animal work as well, that longer exposure would produce greater results in a greater proportion of patients. So when we move to the next phase, to phase 2B, let me just say one thing. This is actually very important. Sorry, I missed this, but in this multiple ascending dose cohort, at these doses that were relevant, the 100 and 200 milligram, one thing that we did do is we segregated the patients or subtyped them into either the insulin deficient, which is shown here, the MARD and the SIDS, and the more insulin resistant patients, so mild obesity related and severe insulin resistant diabetes. And we saw, as we might expect, that those patients who were more beta cell deficient, the MARDs and the SIDS, had a greater reduction in hemoglobin A1C. So here we saw in these patients, again, at week 26, 22 weeks after the final dose, a 1.2% reduction in A1C, compared to still a fairly robust reduction of 0.5% in those patients who really were categorized as insulin resistant. So this is what I was going to get to. So the current study that we're conducting, and actually we will have 26-week data of this study by the end of the year, top line 26-week data. We looked at adults again with type 2 diabetes, this time less than 7 years duration, again poorly controlled with up to 3 agents, and 3 arms to this study. This was a randomized placebo-controlled study looking at 100 milligrams daily for 8 weeks now, so expanded from 4 weeks to 8 weeks. A second arm looking at 100 milligrams for 12 weeks, and then a third arm looking at 100 milligrams for 8 weeks, and then escalating to 200 milligrams for the final 4 weeks. And in this study, we'll have a 40-week follow-up. So we'll go out to week 52, but the primary endpoint is the change in hemoglobin A1C from baseline to week 26. And these are data we'll be presenting relatively soon here, because that part of the study has concluded. And we'll look prospectively not only at the change in the overall population in A1C, but also by diabetes subtypes, so the insulin deficient and the insulin resistant patients, and also by BMI as well, so less than 30, less than 27, and over those values. So to summarize, icovamenib is a first-in-class agent with a very differentiated profile. It's an oral small molecule, so it's taken orally. It is complementary to other medications, and when we wrap up, I'll show some of the data, how we feel it'll be complementary to the GLP-1 based therapies, but also complementary to SGLT2 inhibitors. We feel that we will need a finite duration of treatment. So we've studied 4 weeks. In the current type 2 study, we're looking at 8 and 12 weeks, because the lifespan of a beta cell is measured actually in decades. So we feel we can give the medication for that relatively short period of time, expand the beta cell pool, and get a durable effect. And we'll be testing that also in these trials. So a short treatment duration has been very well tolerated actually to date. It has the potential of being disease modifying, really addressing the root cause of type 2 and type 1 diabetes, which is this progressive decline in beta cell mass and function. We hope to see durable glycemic control, and we've certainly seen that in some of the patients treated for only 4 weeks. And we feel it will have a broad application across people with diabetes, type 2 diabetes, type 1 diabetes, and potentially even some patients with prediabetes. So with that, I'm going to turn it over to Professor Chan to talk to us a little bit more about these diabetes subtypes.
Thank you, Juan. Thank you. Okay, thank you, Juan, for that very elegant presentation. This is always very exciting to see a first-in-class, and particularly this one, because as Juan repeatedly mentioned, abnormal beta cell biology is really the roots of the problem. It's almost like the obesity trigger, the decompensation and giving rise to diabetes, but it's almost like a gun which is loaded, and then the obesity might trigger diabetes. And if we can address the root cause, I think this is going to be very, very, very important. So these are my disclosure. And so, over the next 20 minutes, I just would kind of provide some background, to really activate some discussions afterwards. The complex etiologies of type 2 diabetes, and there is this insulin secretion versus insulin resistance, and there is this dysregulation and disequilibrium, which leads to hypoglycemia, and then the ongoing glucotoxicity, which will have adverse effects on beta cell biology. And then really emphasizing the importance of abnormal pancreatic islets in people with diabetes. And because of all the other factors that actually trigger the diabetes, there is also the heterogeneity of phenotypes. And now we have like 9 drugs, including injectables, and we have very complex pathways. And so, it really, with all the increasing understanding of the pathogenesis and also the phenotypes, I think it comes to a time that we really should not just be calling type 1 or type 2 diabetes, but really, be a bit more precise in our classification so that we give the right drug to the right patient at the right time, to get the right outcome. And that really bring back, the important points of early treatment to preserve beta cell function and change disease trajectory. So I don't really need to remind, the audience that insulin is the key hormone. That is the only hormone that will process energy. That is, of course, all about life. And then for utilization and also for storage in the form of fat or glycogen. And they are very, very small, very few of them. It's once you are born, endowed with a certain amount of islet at birth, you will have to, use this islet very wisely. You handle, the amount of energy that you need to process over the rest of your life. And these are really just some visual pictures really showing that in people with diabetes, there is actually structural abnormality. One is actually the amyloid. Many of you know that insulin is co-secreted with amylin. Not like insulin, which can be rapidly degraded. Amylin, actually, they can form oligomer, and then this oligomer might form beta sheets, and that might actually cause abnormal structure of the islet. Just like all organs, it need to be perfused, and atherosclerosis can also cause ischemic changes. With the obesity, fat infiltration, which can be also very toxic, can also cause changes. And all these oxidative stress can actually lead to protein degeneration. And here you could see some of the deposits of protein degradase within the islet. So there's a lot of structural abnormalities. And this is really just one of those diagrams showing that you have the diet, the physical inactivity, the obesity, which is causing the insulin resistance. On top of that, we have other factors. For example, now we know about aging, for example, also sleep abnormality, depression, etc., which can actually cause the disturbance of the stress hormones. And then at the same time, you have the genetics really governs the beta cell biology. The mitochondrial dysfunction is a very important player. And these two factors, the insulin resistance together with the beta cell biology, really determine the onset of diabetes, and then and subsequently the risk of complications. So this is really a pictorial diagram showing that for each of us, we probably have a threshold for obesity. And Dr. Roy Taylor in his EASD plenary, really advocates that all of us, depending on our constitutional makeup, and that probably is very much related to our beta cell mass, we can only handle certain amounts of obesity. So in 3 individuals, they may all have a different threshold of obesity or BMI at which diabetes become evident. And this, of course, is related to two things. On the bottom, on the bottom line, normally, when you have decreased insulin resistance, decreased insulin sensitivity, or increased insulin resistance, your beta cell function would increase. So this relationship is on a hyperbolic curve. For those people who've got diabetes or impaired glucose tolerance, as insulin resistance declined, they were not able to actually increase the beta cell function and secrete insulin. As a result, they decompensate and develop that impaired glucose tolerance and then later on diabetes. At the same time, there are people who also cannot process that excess energy, which is normally stored in our subcutaneous fats. And when there is excess calories, then they will have to be, you have to expand your beta cell mass, not the fat mass, in order to store that excess energy. And some of ethnic groups, for example, cannot actually expand their adipocytes, and as a result, that can actually lead to the ectopic deposition of visceral fat, which is actually can be quite inflammatory in terms of secretion of adipokines and also cytokines. So this is really and of course this is subject to influence by, of course, your age, your sex, the ethnicity, and also perinatal factors, etc., which can determine your threshold at which obesity diabetes might develop at a certain obesity threshold. So this is well known in Asia. I think if you use the Caucasians' definition of obesity, then none of us are obese. And so these are really well known now for the last 20, 30 years that all the risk factors, including not just diabetes but also hypertension, albuminuria, etc., start at a much lower threshold of obesity, of BMI in our Asian populations. And this is really just showing you the men and the women that in fact the risk of diabetes is already substantial at a BMI of, say, 22. These are the Indians, followed by the Chinese and the Japanese. And so this is even lower for the women. So, of course, we now know that in Asians, normal BMI is 23, obesity is actually 25. So this is really the Asian phenotype that we talk about, and this has been now shown by many investigators in this part of the world, characterized by low body mass index, increased body fat, especially visceral fat. There's very high rates of central obesity and metabolic syndrome. There's a lot of increased inflammatory markers. There is insufficient beta cell response to counter the insulin resistance. There's relatively low rates of autoimmune type 1 diabetes, even in young people, but they are present. And there are high rates of young onset diabetes, increasingly recognized as a major healthcare burden. There's also very high rates of child obesity, gestational diabetes, social disparity, psychosocial stress, and all these add up to give us a very high risk of renal disease and as well as cancer. So there are some differences in terms of our predisposition and also outcome. So obesity is very important, but that is not the only risk factors for diabetes, and this is really the enhanced database showing that in these multi-ethnic groups, even after you adjust for risk factors such as age, diet, exercise, and also socioeconomic status, about 40% of the population attributable fraction of diabetes risk is actually due to obesity. So this is the 95% confidence interval, very consistent. So there's something else apart from obesity that actually causes diabetes. So after all, there are a lot of people who are obese who do not have diabetes. Neither, there are also old age is also important risk factors, and also the majority of old people do not have diabetes. And so, to go back to the beta cell, abnormal beta cell biology is a key factor. So again, it has been well reported that loss of beta cell mass is a hallmark of type 2 diabetes. This has been reported in both Asian population. These are Korean autopsy series, and these are actually Caucasians autopsy series. In this study led by Professor Yoon, he actually systematically looked at the beta cell and also the alpha cells ratio in these autopsy series. And here you could see that in people with diabetes, they have actually lower beta cell mass compared to those who have who are non-diabetics, but not like in the normal people where you actually got fewer glucagon secreting cells compared to the insulin secreting beta cells. In fact, in people with diabetes, there is a differentiation of more alpha cells compared to the beta cells. in the Caucasians, again, you can see that actually whether they are, obese or normal, whether these are control subjects, these are non-obese and obese subjects, whether they're obese or non-obese, they also, once they have diabetes, they have actually lower beta cell mass. The same, again in this study, again obese people have lower beta cell mass if they have diabetes. So this is really diametrically showing the Dr. Yoon study where there is a linear relationship between the BMI and also the beta cell mass. And for the same BMI for people with diabetes, they have a lower beta cell mass. This is a 10-year community-based cohort. During this 10 years, 4,000 individuals. You could see that people who progress, to diabetes as aging, with over 10 years time, the insulin sensitivity falls, but these people cannot actually mount a response, a beta cell response. And this is in contrast to those people who remain normoglycemic, they can actually mount a beta cell response. And these people, they subsequently analyzed that in these Korean subjects, among the 17,000 people, 4.1 actually developed diabetes. And then they used the beta, the HOMA IR and HOMA beta. They found that actually there are substantial people, about 20% to 30% of people actually have beta cell dysfunction or both the beta cell dysfunction and insulin resistance. But in those people who have got low BMI, you could see that there's a predominant insulin deficiency and together with predominant beta cell dysfunction together with insulin resistance. Because of this, we know that actually in Asia, drugs that actually promote insulin secretion is very popular and effective. This is really just to show you some example. This is patients treated with DP4 inhibitors, and then if you actually divide their insulin glucose index, insulinogenic index, you could see that those who got the lowest insulinogenic index, they actually have the greatest response to DP4 inhibitors in terms of A1C reduction. And this is a meta-analysis, very famous meta-analysis, really showing that these are in Asian dominant studies, and that there is a relationship between the BMI and also the response to A1C, so that people who got lower BMI actually have greater reduction in A1C. And also, because these people have beta cell insufficiency, so if you can relieve the insulin resistance, they also respond better. So this is really just the GLP-1 analysis, and showing that, compared to the same dose, the Japanese have a greater reduction in terms of A1C. So why do islets fail, really? I think autoantibodies is very important, of course, and genetic, epigenetic factors, lack of insulin, this might be pancreatic pathology, and of course ineffective insulin action, and both of these have genetic and also epigenetic factors underlying this. I don't want to go into this, but really just to really impress upon you, the complex biology that underlies beta cell biology. There's really a lot of transcription factors which are implicated in the maturation of the beta cells, and then also they cross-talk and then trigger the expansion of the beta cells. And once the beta cell is formed within it, there is also many organelles, including insulin glucose sensing, and then the glucose kinase, and then that will generate the ATP, which will close the potassium channel, open the calcium channel, cause the calcium influx, and then cause the release of insulin. And then, of course, mitochondria play a key role in generating that ATP. And of course, we now know there's a lot of genetic factors that have been implicated in some of these pathways, and they can be rare variants or common variants. And of course, the GWAS is very important. The genome-wide association studies really confirm that beta cell biology is the key player. By now, we have more than 400 loci implicated in type 2 diabetes. The majority of that, particularly the first waves of signals, actually are related to beta cell biology. Subsequently, we also find some genetic variants implicated in muscle and also in fat metabolism. But beta cell is important. So this is one of the latest analysis, because now we've got so many genetic variants, so people are now actually putting together risk scores. And so by doing all this clustering, you can actually cluster the genetic variants into multiple pathways. So many of these are implicated in beta cell, body fat, residual glycemia, lipodystrophy, and also metabolic syndrome, and also lipid metabolism. and obesity. But essentially, the point is the more genetic factors you are, the earlier the diagnosis of diabetes. So there is some, and with these, the beta cell abnormality have a very large effect size. So what about, a family history is really a surrogate, of genetic factors and also shared environments. And this is really just some data showing that people who got family history of diabetes, they have lower beta cell function as indicated by HOMA beta. And the more family members they have, actually they also have lower beta cell mass, lower HOMA beta. And then, the beta function would decline with disease duration, but this is happening faster in people who've actually got young onset diabetes. Important to note that there is at least, about 6% of people who have so-called type 2D phenotype, never have DKA or ketosis, but actually they turn out to have type 1 diabetes. And this subgroup of patients we should not miss. So these are about 2,000 people with young onset diabetes, and then when we measure the glutamic acid autoantibodies actually in the stored serum, we found that 8% of these people actually are anti-GAP positive. And compared to the anti-GAP negative individuals, these people are actually more lean, they have less metabolic features, and they have lower risk of cardiovascular disease, but because they have abnormal beta cell problem or islet problem, they're also more prone to have hypoglycemia. The important thing is because these people are missed, and many of them are also not compliant or actually defaulted, and so they actually have delayed insulin treatment, and as a result they have 3 times increased risk of end-stage kidney disease compared to people who have classical type 1 diabetes. But these people, if they are actually identified, they respond very well to insulin. So this really brings me to the importance of diabetes subphenotypes. We've been talking about this for many years, but I think now the community really recognizes the importance of really subtyping people. So here, the type 1 diabetes, which is mainly autoimmune etiology. Then you have the type 2 diabetes, and this is the non-ketotic presentation. Sometimes they are actually overlap. Some of them, the type 2 actually have larger, and some of these type 2 might also have ketone. Some people with the DKA actually turn out to have type 2 diabetes. And then, of course, the monogenic diabetes and other rare forms of diabetes. So Juan has actually mentioned about this. This is really has been chosen by Lancet, as the most important paper in the last 200 years, because we always think about type 1, type 2. Finally, we have a proper subtypes. And using simple markers like GADA, age of diagnosis, BMI, A1C, HOMA IR, HOMA beta, derived from C-peptide, you can divide them into 5 groups. And they have prognostic significance. They also have implication on treatment. So the SID, these are of course, these are the severe autoimmune insulin deficiency. They need insulin. This one, this severe autoimmune insulin deficiency, they need insulin, but so are the severe insulin deficiency type. And then, of course, the insulin resistant type are the one who actually go on and develop kidney disease. So since that report, I think many groups have reported this, including Indian group and the China group, just now Juan has mentioned it. So quite consistently in both the Indian population and China population, 6% of them actually have autoimmune antibodies. But the point I want to make is compared to the Caucasian, whether it's because of the quality of care or because of delayed diagnosis, Asian people actually have lower BMI, higher A1C, worse beta cell function, actually compare than the Caucasians, even for the same type of diabetes. This is an important one. You could see that in the Swedish group, they have about 17% who have severe insulin deficiency, and in the Indian group and also in the China group, about 1 in 4, and in certain situations, it might be 1 in 2. So again, a much lower BMI, worse A1C, and also worse beta cell function. So important, now we can use some simple biomarkers to really recognize these forms of diabetes. So we applied the HOMA IR and HOMA beta, which is has been validated by CLAMP studies, and you could see the interaction between these two biomarkers. So people who've actually got both both deficiency and also insulin resistance, these people fail more rapidly in terms of insulin requirement. So on average, about 10 years, half about 50% of people will require insulin. But those who have got both insulin deficiency and insulin resistance, at 6 years, half of them require insulin. But if they have good beta cell function and actually low insulin resistance, in fact, they might not actually go on the insulin. So how do we actually measure beta cell function? In a clinical setting, this is the next challenge. But I think HOMA-IR, HOMA-beta is something can be done. At the best, at least in clinic, just a fasting glucose and a fasting C-peptide. Then you can actually use a validated formula to derive HOMA-IR and HOMA-beta. Unfortunately, they have some limitations. If the C-peptide is too low, they will not be able to calculate it. So somebody has developed this C-peptide to glucose index, and basically, if the C-peptide to glucose index is less than 2, then these people are really quite insulin deficient. In other words, they have low C-peptide or they have very high glucose. So for that degree of C-peptide, they cannot control the glucose. On the other hand, if they have very high C-peptide and low glucose, then this is like more than 5. Then these people would be more insulin resistant, and probably you should be going for obesity drugs, anti-obesity drugs. And then the next level is really to determine whether they have cardiovascular outcome. And depending on their C-peptide and also glucose index, you might be able to decide whether they should be on insulin, whether they should be on other form of medications. So this is something that are not widely practiced, okay, because most of the drugs are not actually have indications like this. So I think this is really where this new class of drug might be very interesting. So I finish up really just by showing you, this is again I think looking at actually seeing is believing, right? This is really again a very old studies, but I think sometimes some of these old studies really tell us a lot. Basically 100 autopsy cases, these are healthy individuals, die of natural course, but you could see that actually your beta cell mass actually grow up to a certain age, about 18, and that's it. Your growth, it parallels with the growth of the body weight, and then also the growth of the acinar cells, and also the growth of the islets. But essentially, the point I want to make is these are very, very tiny organs, and they are very, very precious. And once you lose them, you can't, you're in big trouble. So this is a conceptual framework. So all of us, okay, we all have a slightly different startup, right? Basically, your mom and dad give you your DNA, you then express it. So as soon as you are in the womb of your mother, that is already, this expression is already being ongoing. Of course, people who are born preterm also have a problem. They might not have sufficient beta cell. But then you have all these external factors, and these are usually obesity, stress, cigarette, etc. But the point is, given the same trajectory, if you have a low beta cell mass, okay, you are all more likely to get diabetes at an earlier age. And then likewise, even if you have a lot of beta cell, okay, but if you actually indulge yourself too much, you might also actually lose your beta cell function and also have earlier age of diagnosis of diabetes. And I end up by really saying the early age of diagnosis is so important because these people are really the ones that are giving us a lot of the burden in terms of healthcare because of the exposure to this glucose-toxicity environment. So this is really a big study showing that if people were diagnosed before the age of 40, on average they lose these 16 years of life. And then 50 years of diabetes, diagnosed at the age of 50, 10 years of life lost, 60 years age of diagnosis, 6 years of life lost. So if you can delay the onset of diabetes, you will be saving many lives. So with that, I would conclude that people with type 2 diabetes have abnormal structure and function of the pancreatic islet. There are very close correlations between body weight and beta cell mass. Abnormal islet structure and function are due to many, many causes. Rare and common genetic variants play an important role. Perinatal and early childhood development that would affect the expression of these genetic profile, autoimmunity, glucotoxicity, inflammation, etc. the heterogeneity of phenotypes really calls for reclassification and also assessment of the beta cell function in order to prognosticate and personalize treatment. And for that, really early detection and intervention, because we really have the golden period so that, the beta cell can still be preserved, or even, to sometimes they might be able to regenerate in order to preserve the beta cell function and delay disease progression. Thank you very much.
Okay, wonderful talk. And you've been talking about this for a long, long time, the subtyping. I think years. You're ahead of your time here, and I think very timely to have you speaking about this. So I wanted to just present one case study, and we saw several of these actually. Some of the patients have really had pretty amazing improvement in their glycemic control, again, just with 4 weeks of icovamenib in the multiple ascending dose portion of this study. So this is a 29-year-old gentleman with a 4-year history of type 2 diabetes. He was treated with metformin and the SGLT2 inhibitor epagliflozin, and you can see very poor glycemic control of baseline, 9.5% A1C, and if you look at the CGM there, relatively low with respect to the time in range in green at baseline. And the BMI actually, certainly for someone in the United States, very low for someone with type 2 diabetes. And this patient, when we classified him, definitely fits into the severe insulin deficient diabetes. So he was treated in the study with 200 milligrams of icovamenib once daily. And you can see here his A1C response. So this is the treatment period. Again, in this study, they were treated for 4 weeks, continued with the metformin and the SGLT2 inhibitor, and then the icovamenib therapy is stopped at week 4. And what we're seeing here on the x-axis is time out to 26 weeks. And you can see that at week 26, this patient had a 2.5% reduction in hemoglobin A1C from 9.5% to 7%. Again, this is 22 weeks after discontinuation, and really no change in body weight in the study. There was, maintained all of their therapy. Generally, there was some lifestyle counseling, but very much standard things that are done in these trials, and nothing else changed to explain this. And I think very importantly, if we look at the continuous glucose monitoring, the increase in the time in range was very consistent with this reduction in hemoglobin A1C. So the final CGM, the time in range, was actually 90% without any time in hypoglycemia. And again, this is very important. We have an oncology program as well with even much higher doses actually for much longer therapy. We do not get overproliferation of beta cells and hypoglycemia. We've not seen significant hypoglycemia in our patients with type 2 diabetes, and the drug was very well tolerated. In this trial, we also looked at HOMA-B as well as stimulated C-peptide with oral glucose tolerance test. And again, looking at baseline and then at week 26, the HOMA-beta very low, about 20 here, with about 190% increase over time. And the C-peptide also increasing significantly from baseline to week 26. Actually, so in a sense, corroborating that this improvement in glycemic control was due to an improvement in beta cell function. This patient actually was treated by an investigator, a principal investigator, who was also the patient's primary care giver in diabetes. And we had some follow-up subsequent to the 26 weeks. The A1C actually continued to decline, and by week around 40 or so was actually in the normal range, and the patient discontinued metformin. Again, this is an anecdotal case study, but it really makes the point that even with only 4 weeks, we have some very, very impressive results. And again, we'll see how we do in the expansion portion now with 8 and 12 weeks of therapy. Something else that I wanted to share before we wrap up, just briefly, is the fact that Menin actually suppresses GLP-1 receptor expression. And this has been known for some time. We've shown this in our lab as well. And what we've shown also is with icovamenib, if we suppress menin activity, we actually get an increase in GLP-1 receptor expression. So more GLP-1 receptors, we're going to get an increase in the incretin effect. So I think this is very important. And I'll show a slide of some of the work we've done with islet microtissues with both tirzepatide and semaglutide. But not only are we increasing beta cell mass, where you might get an improved incretin effect from GLP-1 therapy, but also increasing GLP-1 receptors on the beta cells as well. And here we see the increase in GLP-1 receptors with menin inhibition. And one of my last slides here, and then we'll get to some Q&A, but basically this is work done with donor islets. So these are islet microtissues, and you can see here at hyperglycemia, sort of about 145 milligrams per deciliter, treated for 8 days with 3 different doses of the menin inhibitor, icovamenib. Then it is stopped and given tirzepatide, the dual GIP and GLP-1 receptor agonist, and we measured, or our lab measured, insulin or glucose-stimulated insulin secretion. So again, with the 3 different doses of icovamenib, stopped now, and then tirzepatide administered without icovamenib and with the 3 doses, and what you see is an enhancement. This is tirzepatide alone and glucose-stimulated insulin secretion, and this dose-dependent increase in glucose-stimulated insulin secretion caused by the tirzepatide with pre-treatment with icovamenib. We have very similar results with semaglutide as well, and as I mentioned previously, we do have in early clinical development an oral small molecule GLP-1 receptor agonist, BMF-650, which we will assess. But I think this is very interesting and again shows the potential complementary mechanisms with other anti-diabetic agents. So I'll end just with a summary slide. So icovamenib is an oral small molecule. It's a covalent menin inhibitor. In clinical trials, it's been very well tolerated. It is complementary to other available agents, and very importantly, non-chronic dosing. So we feel that, again, a finite treatment period. It does affect or improve the root cause of diabetes by proliferating beta cells, and we think we'll have continued glycemic control, so durability of the effect beyond actually drug therapy with icovamenib. So with that, I will say that please visit our website. It's very small here, biomiafusion.com. We have a lot of information. You can scan this QR code as well, but certainly a lot more information. And as I mentioned, we will be disclosing top-line data from the 8 and 12-week dosing periods in the expansion portion of our study, Covalent 111, later this year. So please stay tuned for that. So with that, I want to thank you very much for a wonderful lecture, and we do have a few minutes now for questions, if anyone has any questions.
Thank you, Juan. This is very exciting. I think from patients' perspective, I think pill burden is something that they always complain. The outlook of actually being on some drugs for the rest of their life. So, this dosing or intermittent dosing, and then try to maintain the body weight in order not to sort of, put burden on the new beta cell mass may be a very interesting concept. Just one question, this study is ongoing, any AE reporting, any SAE reporting in these patients?
Yeah, as you may know, we did see actually in the multiple ascending dose portion, we saw elevations in aminotransferases. These were almost exclusively transient. They occurred at higher doses, and very importantly, there was no increase in bilirubin, no issue with synthetic capabilities of the liver, so INR was not increased. And we did a very deep dive looking at that along with many DILI experts in the US and worked with FDA. The clinical hold was lifted, but we do initiate therapy. And in fact, in the expansion portion, which we'll be reporting out, the starting dose was always 100 milligrams. And even in that third arm, I mentioned that we start with 100 milligrams for 8 weeks and then escalate to the 200 milligram dose. We didn't see clinically significant aminotransferase elevation. So we think it's probably a physiologic response to shifts in insulin and glucose and potentially glycogen accumulation in the hepatocyte. But we'll be looking into that more and certainly monitoring through the trials. But very well tolerated from a side effect profile. With respect to no GI side effects that were significant, nothing like that. Anchita.
Yes,
Please.
Dr. Chan, you mentioned that there is a need for early diagnosis of type 2 diabetes patients. So from your perspective, what would be some of the ways we can diagnose, and do you think this is kind of an important need for a medication to hit those kind of, before the diagnosis of type 2?
Yeah, I think everybody's now really going into the prevention space. I think there are people using different kind of risk scores, right? So based on multiple, a lot of epidemiological studies, they have used clinical risk scores, right? Age, sex, BMI, and for example, family history. These are, some of the key risk factors. And then they would have about 70% accuracy, and to identify those people. Then, if you then do OGTT or A1C on them, you will actually find that they have diabetes. Now, of course, a lot of people use fasting glucose and also A1C to diagnose diabetes and pre-diabetes. But I think there are now data showing that actually it's good that if you use fasting blood glucose and A1C to diagnose diabetes, but I think you'll miss quite a lot of diabetes who are only diagnosed on 2-hour plasma glucose, and this is very much a feature in Asian people. We can have a normal fasting glucose, but if you do an A1C, you'll be amazed, how high the 2-hour glucose can go up. And that again reflects that inability of the beta cell to secrete insulin in response to a glucose challenge. There is also now a move of using, for example, genetic risk scores, because now we've been doing genetic research for more than 2 decades, right? And I think, with more and more evidence coming up, people are using these genetic risk scores, right? Multiple SNPs coming together, and then of course together with some of these modifiable risk factors, and then to try and identify those top 20% of people who might be very high risk, and therefore these people need to be monitored, maybe OGTT or A1C, etc. And as soon as you see that their blood sugar is still good, then I think that's the time for action. So on that point, actually, we have just published because now for type 1 diabetes, we have these 4 stages, right? You have the 4 stages based on the genetic, based on the antibody, and also beta cell abnormality, and then the clinical staging. Recently, we have this IDF has endorsed the use of 1-hour glucose, and if the 1-hour glucose is greater than 8.6, these people almost have IGT or diabetes. And so they're trying to, even though their fasting glucose and 2-hour glucose are normal. So we are advocating that maybe we should be using, the 1-hour, 2-hour glucose, fasting and 1-hour, 2-hour glucose, in order to stratify people by risk categories. And so if these people already got high 1-hour glucose, and this is 4 decades of research showing that 1-hour glucose is very predictive of diabetes and many outcomes. And so this might be a very early marker of people who might have a problem.
Yeah, it sounds like that, awareness needs to go there to educate the people that go ahead and get diagnosed before diagnosis of type 2.
Yeah. Family history is very important, right? I think we physicians should really do a bit more screening. Once you see a person with diabetes, particularly those who are lean, got a family history, who have young onset, why should they have diabetes, right? So you try and manage them, but I think their family members should also be informed, and that they are probably at risk as well. We're doing quite a lot of study on young onset diabetes, and we just discover a lot of their family members. If you do OGTT on them, many of them actually have either frank diabetes, undiagnosed diabetes, or IGT. I think these people might well be really important individuals that might benefit from this sort of 4-week therapy, and then see whether we can, stop it from developing diabetes.
Sure, thank you very much.
Okay, so in our last 10 seconds, this is a short answer, Professor. How would you subtype a patient that comes into your clinic with type 2 diabetes? What would you use?
Basically, I do anti-GAT and C-peptide.
Anti-GAD and
Yeah, I do
C-peptide.
C-peptide
Okay.
and also anti-GAD on them, right, you know.
Yeah.
I think C-peptide, if it is less than 90, these people are very interested. This is picomoles per liter, people use different units. But in the field of diabetes, if they're less than 90, okay, they are very short of insulin.
yeah.
If they're between 90 to 250, they are moderately insufficient. If they're greater than 250, then you do have to interpret it together with the sugar.
Yeah.
Right?
Yeah. And we see like the Japan Diabetes
That's
Society
right.
guidelines
Yeah.
saying, particularly to primary cares, use BMI. You know,
Yes, that's
BMI
right.
less than 25, this is probably an insulin deficient patient
Yeah.
because it's a little, for some people, too complex to be doing C-peptides and stratifying,
Yeah,
but I
but
would
we already
agree.
practice it, right?
That's-
Looking lean people, we tend to actually give them the insulin secretagogue type of drugs,
Right,
yeah.
right. Last question, or
Yes,
we have two
so-
questions, let's do two more.
Ishimura from Japan. So congratulations for great presentation. And I have a question about your menin inhibitor. So it's oral.
Correct.
So is there any reason that why you give your menin inhibitor only once?
Well, it can be given once or twice daily, but
No, no,
are you
no.
say, when you say once, oh, for a short period
for a
of
short
time?
period.
Of course. Well, because the mechanism of action with respect to what's happening in the eyelid is proliferation of beta cells, and the lifespan of a beta cell can be decades. So the idea is that we're
Oh.
proliferating new beta cells, building the beta cell pool, and this can last for a very long time. So I think this is one of the, as you were alluding to, one of the real benefits clinically of this, since poor adherence and persistence is such a big issue in patients with any chronic disease, including type 2 diabetes, is you've got an oral medication that we think, and we'll see what the data show, we think though, based on what we've seen, can be given for a relatively short period of time and then stopped and should persist over time.
Okay, so maybe in the future, maybe every 10 years or something like that?
That's what we would hope. Maybe never again, but I think it's going to depend also on the lifestyle of the patient, if they also lose weight, if they, you know, as the glucose toxicity goes down. But there may be some patients that do need to be retreated, and I think we'll study that over time as well. But that's a great question, and that's
Thank you.
why.
Very
Okay,
tough
well,
situation.
thank you very much. I think we'll need to wrap up. Our booth is going to be open tomorrow. We actually have an oral presentation tomorrow to discuss the design of our type 1 trial as well. So please stop by, and we'll be around for a while for more questions if you have them. Really want to thank you for your attention and look forward to staying in touch. Thank you.
Thank you very much.
Professor.
Thank you.